into this, which chemokine, which factors drive stem cells here to develop into cancer. We have no idea what the influence of stem cells on the cells of the immune system in this type of cancer is like. We know that cellular stem cells will absolutely prevent the formation of dendritic cells, by example, but there's very little knowledge here. And in particular, we have no idea how stem cells themselves develop into metastasis and what drives them and how they shirk from the immune system again. So there are many, many, many new questions coming up. I'm sorry for the slide because this is in German, but I just want to use this to show you that there are many stem cells in the cancer that are actually characterized by several stem cell markers, but these stem cells are just basic stem cells which would be used for wound healing or anything. It's nothing to do with a tumor stem cell. So far, we only have a CD44 lineage negative positive, CD44 positive lineage negative tumor stem cell. The rest is just a stem cell. But what is the idea behind it to identify these cells into head and neck cancer? We've taken primary material from patients and have been analyzing or cell sorting, by example, CD44 positive cells as well as CD59 positive cells. And we find this great individual heterogeneity among the presence of these cells, the quantity of these cells in the tumor, and so forth. We're currently evaluating how the frequency of these cells influences the clinical outcome, and it does influence the clinical outcome. I'll come back to this in the next slide. But I want to draw your attention to this also. We've been staining all the permanent cell lines available for head and neck cancer, and basically each cell line has a CD44 positive, 100% positive phenotype, which renders us the question whether all of our permanent cell lines we're working with in the lab is a stem cell line instead of a cancer line. So we don't know what we're actually dealing with, stem cells or cancer. Or is it the same entity? We don't know. What we found is, we found expression profiling for several stem cell markers, the first two being out of metastasis. Second portion here, the 3 patients here, is primary material from recurrent cancer. And what you see is that the cells described by Prince, CD44 positive, lineage negative stem cells, are present in metastasis and the recurrent cancers. So it's a clear marker for a tumor that is very, very aggressive. And now comes the next story, because all of these cells are aggressive because they can shirk from what we do with the tumors. And what we do with the tumors is resecting, okay? We do chemo and radiotherapy. And what we find is that these cells, especially this entity of cells, in primary material and in the permanent cell lines, show an increased chemoresistance and radioresistance. This is an example from cell culture experiments where we have the primary cancer cell line here, a metastasis cell line from the same patient here, and you see that the sensitivity to chemotherapy is much increased in the metastasis. So the problem actually what we have is that these cells have many, many mechanisms of multi-drug resistance, DNA repair, and so forth. And this comes to the point where we have to think about our therapeutics and we have to reconsider what we actually do. And I'm absolutely, absolutely with you. We need an individual tumor profiling as each tumor is heterogeneous. Be it a chip, be it a serum, be it whatever. We need an individual profiling for each patient from my point of view. And if we consider that we're facing tumor stem cells and that these stem cells are those cells that lead us to recurrence after a certain while that we think we've eliminated the cancer and it comes back all of a sudden. If we face the tumor stem cells, we need actually drugs that target multi-drug resistance mechanisms, that target DNA repair, that block self-renewal cascades like WNT or BMP signaling, that accelerate the differentiation of these cells into differentiated material, which we can eliminate again. We need to block the homing of these cells to tumor or to any other site in the body. We need to further know what happens in the stem cell knees, which milieu drives the stem cells, and we can actually reverse the whole story like we did that before and use tumor stem cells to come to the tumor and use them for innovative vaccine strategies.
So, Barbara, in the future, we can remove an organ or most of the organ, including the tumor, and put some stem cells in there, and it will be replaced and remodeled.
That's another aspect. Yeah, no.
We do not need to do so much of reconstruction.
Yes.
They do it in the myocardial infarction, for example, put some stem cells in. The orthopedic surgeons are using it also for some muscle replacement.
We cannot replace organs so far. We can replace some of the cells, but not organs yet.
And when we get older, get some problems up here, we put in some stem cells and get refreshed.
Don't use tumor stem cells.
Yeah,
Finally, Carl, now, is there any place for surgery?
Yeah, well, I think you build a wonderful bridge for the future of surgery, because I think the T1s and T2s will always be the job for surgeons. And if you have a T4 or a T3, it is the ideal approach to combine all the tools we discussed, which means a multimodal approach to these tumors. Because when I was younger, 30 years ago or 20 years ago, I did very radical surgery. We started with jejunal free flaps and so on. But unfortunately, the survival was not improved. And so I think the future is, in all cases, to try to make a minimal invasive organ preservation via surgery, and using new tools like navigation, endoscopy, and so on. And regenerative medicine. This is what you was preaching with Barbara. This is maybe in the future we don't need a free flap to reconstruct the nose you cut. We will breed the new nose from cartilage, from stem cells, and from skin, and so on. And I think this is the future of surgery in the perspectives of our topic today. It will be a lot of fun.
Thank you. We haven't really touched upon during this conference the organization of head and neck oncology, etc. But we have heard that, for example, in skull-based surgery, there are very few cases, and we have heard in other fields that the amount of cases are very limited. Should we in Europe, for example, have instead centers for oncologic treatment? We already have them, but should we, for very rare cases, have it more centralized than we have? Because, I mean, surgeons need training, practical training. And if we are leaving a lot to chemoradiotherapy, and I mean, the less trained the surgeons are, the more keen they are also on joint meetings to say, let us give the patient the chemoradiotherapy. Because there will be very few of us that are trained enough to do the major head and neck surgery, if it is this development. Perhaps we need then to concentrate skull-based surgery and other forms of surgery where we have only few cases to certain centers in Europe. And perhaps we do not need more than 15, 20 such centers in the whole of Europe. I'm a little provocative, and many people will turn around and say, what is coming here? But I think if we are not looking at this within our specialities, I think administrators will do it in the future. And I think that is one thing, the organization. I touched upon the training of the people who also are involved in head and neck. They need a broader training. I mean, if you're in ENT, you are not a head and neck surgeon when you are finishing your 5-year training, by no means. You need many more years. You're not fully trained until after perhaps up to 10 years. And that is one thing. So I'm a little provocative, but I think this is important. We are only 5:45 now, and I give an open floor for those who have been panelists in the previous panels. What do you think is the future? It's not so easy to be sitting and looking at 5-10 years perspectives. I mean, we have been prognosticators in many fields, but you always know that prognoses are bad. After 5-6 years, you see that it's going another way, because other things are coming in, and it will never be as you are planning now in 5-10 years' time. Things are coming in. Who believed that in 20 years ago, 15 years ago, that the gene technology should come in? Nobody nearly. And nowadays it is really heavy in with stem cells, etc., etc. New techniques, new things are coming, and it's a dynamic process, the whole thing. Jan van Morken, you're sitting there. What do you think will happen within chemo, radiotherapy, etc.? Do you agree with Barbara here?
Well, I'm supposed to speak also a little bit about perspectives tomorrow.
I bet you can say something today.
But,
it's good to repeat things.
well, I think, first of all, maybe we should persist in prevention of certain things. We are not talking so much about prevention anymore because we think it's much more sexy to talk about new drugs and new approaches. But I think the major advantage that we can reach is by stressing more prevention. And of course, although we see in the Western world that there is much less smoking than it has been in the past, there are other areas where it's even worse than it was before. So I think we should persist in giving attention to prevention. I think that that's a very important thing.
I mentioned it a little when I said non-smoking, HPV vaccinated world but there are many more things.
Well, the point is that, again, this is not stressed by everyone so much, but what is worrying me very much is that with all the addition of the treatments that we are giving, we're adding a lot of toxicity to the patients. And if you see that in certain studies with long-term follow-up, people are dying of complications of our treatment, I think that we should focus more on that aspect and not only to try to increase the toxicity of all these treatments, but to see whether we can make compromises between new approaches, like, for instance, induction chemotherapy, followed by less aggressive local treatments, if that is possible.
Ladies, hand up first. No, you had your hand up.
Okay. Well, I see that what I'm saying is already they're jumping on the chairs already. So that's.
No. I think we agree. The problem is also with your point. If we should concentrate patient care, let's say in the skull-based center, and so, especially our patients are special patients. We are surrounded in Mannheim with a lot of vineyards and breweries and so on, and the same stories in Antwerp and maybe also in Bergen. And the people with the T3s and T4 don't like to travel. Business is local. And the other point is if their survival is only 1 or 2 years, we know it, if we do a multimodal approach or not. And if they are concentrated in we can put them in nursing homes and look what will happen. So I think your point is very important. We should bring as many patients in the T1 and T2 group by prevention, by awareness in the public that they are doing a risky life and so on. And then the remaining T3s and T4, and these are more and more in my personal patients and so on, then to help them with an intelligent, combined, multimodal approach.
I think you are partially right, but not totally, because we were looking at forehead cavity carcinomas in a series when I was working in Sweden and looked at the anamnesis. And 70% of the T2, T1, T2.